So I'm just going to go over this, and actually Andre went over a lot of these, so you should have the answers. So you injected your patient, and this is the images you got. There's no contrast at all in the image. So what things could have happened? MI's too high. Bubbles bursted. Gain. Actually, gain is not an answer. Well, unless you have the gain really, really, really low. But, you know, gain is not going to eliminate bubbles. It may make them brighter or darker. But MI will obviously bust the bubbles so you won't see them. Against stopcock. Haven't waited long enough. So, number one, make sure the contrast agent was injected. So if you actually picked up you picked up 2 salines instead of a contrast, remember that. Make sure that the contrast agent was completely activated or shaken. So again, sometimes you drop the agent, something happens, the sonographer lost the lesion and you have to wait. You look at the thing, take the syringe off and go ahead and shake it up to make sure those bubbles are nice and shaken. The IV infiltrated. Make sure that that clamp on the extension tubing is open. Make sure that the contrast setting is on and you're not using MI. And as Andre mentioned, some places have filters in their IVs. This is particularly in intensive care units, in the surgical suite, and maybe in the ER. These filters are put in when they're in the saline bags. So we've actually trained our anesthesia personnel that when we do a procedure, because they do use this filter, they can't inject up by the saline bag. We make them put a port right by the hand. We want the small dose of contrast we have, we want it to go into the vein and be flushed in. If you put it way up here, it gets so diluted by the time it goes in, or it could be filtered out by the filter, that you don't get a good bolus. So now we see some contrast, but not a lot. So we got a crappy injection. So the enhancement is very weak. What things do we got to think about? Not enough contrast. Was too diluted. MI may be too high. Too slow of an injection. So, number one, make sure the dose of the contrast is correct. So the 2 probably most used agents are about a factor of 10 difference in what you inject. So if you got confused, you may have only injected 1/10 of what you needed to do. Make sure that the contrast agent was not injected into the saline. So again, that's that little blue button. If you have the blue button set to the side so that it's pointing to the patient and you inject the contrast will go into the saline flush, get diluted, and then when you inject, you're injecting diluted bubbles into the patient. That'll give you a very weak injection. Make sure that the IV, again, didn't infiltrate. Make sure that the MI power is low. And make sure that the extension tubing is not long or of small diameter, because then the saline flush cannot deliver the contrast into the vein. Also, when you're doing small parts, breast, thyroid, testicles, the center frequency of the linear transducers is higher, and it's higher than what the bubbles normally resonate. So you may have to give more bubbles. So in these cases, you may need to give a second injection. The other option is to go to the pen setting, even though from the B mode you may not need it. If you drop that frequency down, you may get more enhancement. Thyroid, I think we're finding that maybe the standard dose is going to be okay, but definitely for breast and prostate, we always give a double dose. Again, make sure that the contrast is completely activated. And again, look at it. If you see it's layering, shake it up before you inject. Make sure that there's no filter again, and no or very late saline flush. So you got a good bolus, but after a couple 20 seconds, this image is black. Should have lasted for 5 minutes, not 20 seconds. So you got a good bolus, but then the bubbles disappeared really fast. So high MI, right? We're busting the bubbles really fast. So confirm the MI is low. Make sure the contrast was adequately activated. And make sure you're not using a very high imaging frequency. So again, if you use a very high imaging frequency, you may not see those bubbles. Andre showed you this one. There's a loss of contrast in the near field. So if you look at the top of that liver, there's a 1 centimeter, not much enhancement. So again, the MI is too high and you're burning off bubbles. You need to lower the MI. I think this was more of an issue in older equipment. As we've come to newer equipment where the MIs are standardly lower, we're not seeing this effect too much. And again, as Andre showed you, the focal zone can make a huge change. You should always have the focus zone in the far field, either below the image or at the end of at the bottom of the image, because that can also cause this effect. Opposite, there's a loss of enhancement in the far field. So we kind of got enhancement up to here. And I think this is important to recognize because sometimes when we look at these lesions, so we had a cystic renal mass that was kind of sitting right here on one patient. Well, it's important that we don't have enough contrast down here. Half of the lesion wasn't there. It turned out that that actually was a cystic renal cell carcinoma, but we didn't see enhancement in it because we were below the level of where we had adequate bubbles. So again, you need to maybe change the patient position, lower the frequency, go to the pen setting to see if you can do that, but you shouldn't call a lesion no enhancement if you don't see contrast behind it. Yes?
Sometimes when we see something with grayscale, we think that we see it better, like if we've got two curvy linear probes, like a 5 and then a higher frequency, a 7.5 mean frequency. So sometimes I've noticed that my technologist will decide, well, we could see the lesion best with a higher frequency probe, like the resolution's better and the grayscale when we're using high MI is great. And so sometimes when you get this picture is when you might decide that you're going to use the higher frequency probe for the contrast as well. And so you already alluded to this. When you're doing contrast, I'm always thinking that when we're looking at something that's really superficial, oh, we can use a higher frequency probe and this is going to be so beautiful. Well, it's not. And the reason it's not is because the bubbles oscillate really at the mean operating frequency of that big abdominal probe. And so almost without exception, if that was done with a higher frequency probe, if you just go to the big probe. And so oftentimes, if we're doing something that's uncertain to me, I always say start with the bigger probe. Don't go to the smaller one because you're much more likely to get a better study and get that better penetration. And always consider what you're going through also, because if you're going through a big fat abdominal wall like that one right there, or a big fatty liver to get to where you're going, you need the bigger probe.
Right, so again, the point is, remember, you're doing B mode, you're going to do all the things you've been taught to get a really great high-resolution image. That doesn't translate to having a better bubble image. So the bubbles resonate around 2.5 megahertz, and again, most of the contrast-specific transducers try to get as close to that as possible, but it's very hard for a 9-linear or a 10-linear probe to get down that low. So those are the cases you need to inject more bubbles. So for this case, in general scanning in the far field, I think now with the machines we should probably say 8 centimeters is difficult. Try repositioning the patient so the lesion is closer to the transducer. Raising the MI or power will only make it worse because you're going to burn off more bubbles. Although it's not intuitive, sometimes if you decrease the MI more, you'll actually be able to see a little bit more because you won't be busting as many bubbles. That works sometimes, but not all the time. And again, use a lower frequency or the penetration setting of available to look at those deeper lesions. So here we've got shadowing in this image. And Andre mentioned this too. Too much contrast, right. So again, the contrast dose is too high. So again, this is kind of what you're going to see if you use the package insert dose. It will eventually go away as the bubble concentration drops. But if you're really looking at something that you need to see the arterial phase, you're going to need to do another injection. So if you see that, do another injection with half the dose. Again, with time, this shadowing will go away, but you've completely missed that arterial. So maybe doing a renal case may not be important to do another injection, but certainly in a liver where the arterial phase is much more important, it's probably better to do a second injection. And again, if you inject really fast, you're going to get a bigger bolus, you'll get more shadowing. Same thing as giving another higher dose. And then we used to mention this. So we want to give a second dose, but there's still enhancement left from the first injection. And I'm just going to go to the answer so you guys can have a little bit longer coffee break. Maybe Stephanie will give you 3 minutes instead of 2 minutes. So again, all these systems have what's called a flash button or something on that order, where if you push that button, you get a bunch of high MIs, and then the image comes back in low MI, and you can watch the bubbles reflow into that area. So that does bust bubbles, but it only busts the bubbles in that one little area. So if you sat there, you would just be doing this, and you would, it's just easy to wait till the bubbles are gone. So what I like to do, turn on color Doppler, big field of view, put it over the aorta or the heart or even over the liver. But what you'll notice is these bubbles are really Doppler enhancers. So you'll have huge, huge signals when the bubbles are there. And then you can watch the color Doppler, and as you see the color Doppler go back to normal, you know the bubbles are gone, and now you can go back to your contrast mode and give your second injection. So this flash method is not what you should use. So Andre showed you this one too. There's less contrast in one plane than the surrounding tissue. And again, for the sake of time, when you have an MI that's too high and you're staying in one location, you're busting bubbles in that one location more than in front or back of the transducer. So if you quickly turn the transducer to 90 degrees, there's less bubbles because you bursted them. So you'll see this band of no contrast. This will quickly disappear as bubbles from anterior and posterior to the liver now reperfuse that area. And again, I don't think we see this as much as we used to in the past because we're using lower and lower MIs as technique gets better. And sometimes you'll notice if you start to move the transducer, you'll notice that you got more bubbles than less enhancement. And again, that's partly because in those areas that have less enhancement, you've burned off the bubbles because you were staying there and you had an MI that was high enough to destroy some bubbles. How long do I need to scan? And again, it's going to depend on which organ, and I think I'm just going to leave that until we go to the organ-specific areas. In general, for livers, particularly in chronic liver disease, when we're looking for HCCs, we have to scan much longer. Metastases we usually can pick up in the first minute or so. You may not have to go out quite as long. I find kidneys, I think within a couple minutes we know the answer, so you don't necessarily need to scan as long. But as we go through all these organs, it give you a better idea. If you're going to do quantification, I don't know if this clip is going to play. No, it's not there. Going to play. You know, we can do quantification, and most of the vendors now have some quantification package. So here, this is actually a hepatic adenoma, and the clip isn't going to play. But you can see the green is the normal liver parenchyma, and the yellow is put on the hepatic adenoma. So visually, you can see the bubbles came in. The adenoma enhanced more than the liver and did not wash out. So you can use these things. There are many other applications for doing this, but if you're going to do this, there are a couple things you have to remember. You have to keep all the settings the same. So gain, power, imaging frequency, etc. have to be constant. You can't turn the clip on or off or hit the freeze button because the interpretation will only be on the one segment. So you need that continuous clip. And if you use the flash destroy and replenish technique, then that's also going to disrupt the bubbles. And I'm going to say if you use the flash technique, you really can't look for washout. So, you kind of destroy your ability to look for washout if you use that flash. So the flash, I think Stephanie will probably go over some applications in the liver. And again, each vendor may have some specific requirements for the quantification. So you may want to make sure you know what the machine requires before you start. We talked about consent. Again, right now, this is an approved technique. So we do the same thing as we do for CT and MR. When we do off-label use, we do mention it to the patient, but we do not have them sign. Actually, we don't really even ask them for consent. We just let them know that we're doing the same technique. We're just putting the probe in a different location. In the past, when we had the black box warning, we had monitoring of the patient, no longer required. Again, usually when we see some side effects, it's usually gone in less than a minute. We let the patient go. If these persist by the time we end with the exam, I usually have the nurses do a set of vitals and have them sitting in the back in the PET room where it's nice and quiet, and usually, again, they all resolve in another 10 minutes or so. So we've never had anyone that we had to worry about having a significant thing, and I don't even think we've given Benadryl or epinephrine to any of these patients at all, but again, that could happen. Other contraindications, and again, really only if you have a hypersensitivity to that agent. So basically, if you're giving this as a first time, you're never going to need to worry about that. Oh, any other questions?